Welcome. In the previous two sessions, we have discussed primary open angle and primary angle closure glaucomas. We will now discuss the secondary glaucomas and begin with the secondary glaucoma entities which have open angle mechanisms as the predominant cause of glaucoma. Following which we will be discussing those entities which have angle closure mechanism as the predominant cause of secondary glaucoma, and then we will be discussing those glaucoma entities which have combined open angle and angle closure mechanisms contributing towards glaucoma. So in this session we will be starting with secondary open angle glaucoma and discuss pseudoexfoliation syndrome and pigment dispersion syndrome. Pseudoexfoliation syndrome is actually a systemic disorder of the extracellular matrix, and it is characterized by deposition of fibrillar material in the anterior segment. This deposited material can be clinically detected particularly on the anterior lens surface as shown here in this photograph, and in the pupillary margin and various other locations in the anterior segment which we will be discussing. And this material has also been histologically detected at these locations. The material has also been detected in non-ocular tissues such as skin, lungs, heart and liver, and this material is said to be elastic tissue in origin and produced by various epithelial and endothelial layers in the anterior segment. On presentation, pseudoexfoliation syndrome is typically unilateral or highly asymmetric between the two eyes. It rarely occurs below 50 years of age and most commonly occurs after 70 years of age. So it is basically a disease of elderly people. Pseudoexfoliation syndrome and glaucoma does not show any sex predilection, and both genetic and environmental factors are said to contribute to the pathogenesis of this entity. And among genetic factors, almost all PEX patients in Scandinavian countries have single nucleotide polymorphisms in LOXL1 gene, which produces the lysyl oxidase like protein 1, and lysyl oxidase takes part in cross-linking of elastin monomers into elastin polymers in the elastic tissue. Interestingly, not all individuals with these LOXL1 mutations have pseudoexfoliation, and other genetic loci have also been associated with pseudoexfoliation. And among the environmental factors known to predispose towards pseudoexfoliation, we have residence at higher latitudes, exposure to ultraviolet radiation and caffeine. Among the clinical signs of pseudoexfoliation syndrome, detecting deposition of fibrillogranular exfoliative material in various portions of the anterior segment of the eye is the most important, and the location where it can be most easily detected is the lens capsule, where the deposition takes a bull's eye configuration, best seen with the pupil dilated as shown here in this photograph, with a clear zone between two zones of deposition, a central disc and a peripheral zone of deposition. And the clear zone between these two locations is due to rubbing of the posterior surface of the iris on the anterior surface of the lens during pupillary dilatation and constriction. Radial striae may be seen in the peripheral zone as seen here in this photograph. The central disc is not found in all patients with pseudoexfoliation as seen in this photograph, but the peripheral zone is consistently found in all patients with pseudoexfoliation. The pseudoexfoliation material rubs against the pupillary margin of the iris, causing pigment dispersion, which is another feature of this condition which overlaps with pigment dispersion syndrome. Deposition of this material at the pupillary margin appears as white flecks as seen here in this photograph, and it can be associated with loss of pigment of the pupillary ruff. Deposition of this material can also be found on the ciliary processes and zonules, and it is said that deposition at this site occurs earliest and can be seen by a gonio lens through a dilated pupil or a patent LPI. This material can also be seen on the IOL in pseudophakic eyes as seen here in this photograph, and on the anterior hyaloid in aphakic eyes as seen here in this photograph, and also on the anterior hyaloid in eyes which have undergone yak capsulotomy. Deposition of this exfoliative material and pigments as well can be found on corneal endothelium in pseudoexfoliation. We can see here deposition of pseudoexfoliation material on the corneal endothelium. And the corneal endothelium in pseudoexfoliation syndrome can demonstrate guttata-like changes. As we have discussed, exfoliative material is seen in the pupillary border of the iris, and inadequate dilatation of the pupil is one of the characteristic features of this entity and is very important to remember. And peripupillary iris transillumination defects, which have a moth-eaten appearance, is found in pseudoexfoliation syndrome but may be difficult to observe in eyes with thick brown iris. In contrast, the iris transillumination defects in pigment dispersion syndrome is mid-peripheral and spoke-like. I could not find a non-copyrighted image of peripupillary transillumination defects, and please look up for one on the net. Eyes with pseudoexfoliation typically shows opacity of the crystalline lens, which is usually nuclear in character. And when the presentation of pseudoexfoliation is unilateral, which is actually the case in most pseudoexfoliation patients, the lenticular opacity is also found unilaterally or asymmetrically much more advanced in the eye with pseudoexfoliation. Weakness of the zonular apparatus of the crystalline lens is another characteristic feature of pseudoexfoliation, which along with inadequate dilatation of the pupil is very important to remember. And this zonular weakness can cause phacodonesis, that is tremor of the crystalline lens, or frank subluxation or dislocation of the crystalline lens. Both zonular weakness and inadequate dilatation of the pupil increases the risk of cataract surgery in patients with pseudoexfoliation. And pseudoexfoliation is the most common cause of IOL dislocation, and this IOL dislocation is usually associated with capsular phimosis. Capsular phimosis is decreased diameter and increased fibrosis of the anterior capsular opening following cataract surgery. Gonioscopy in eyes with pseudoexfoliation shows heavy pigmentation of the trabecular meshwork as shown here in this photograph, but the pigmentation of the trabecular meshwork is often patchy and uneven in pseudoexfoliation, in contrast to pigment dispersion, in which the pigmentation of the trabecular meshwork, as we shall see, is homogeneous and dense. There can also be pigmentation anterior to the Schwalbe's line called Sampaoli's line, which is found most commonly in the inferior angle as shown here in this photograph. PEX material as shown here in this photograph can be found in the anterior chamber angle, and there can be a component of angle closure also due to forward migration of the crystalline lens due to zonular weakness. Elevation of the intraocular pressure in pseudoexfoliation occurs due to obstruction of both aqueous and uveoscleral outflow pathways by exfoliative material as well as dispersed pigment. And the intraocular pressure in pseudoexfoliation is found to be higher with larger diurnal fluctuations as compared to primary open-angle glaucoma. And the IOP is further elevated with pupillary dilatation due to significant pigment dispersion on dilatation of the pupil. Non-ocular systemic manifestations of pseudoexfoliation syndrome include ischemic vascular disease such as cardiac, cerebral, and renal, and includes aortic aneurysm, hearing loss, elastic tissue abnormalities such as chronic obstructive pulmonary disease, inguinal hernia, and pelvic organ prolapse. But there is no report of increased mortality in pseudoexfoliation syndrome. Pseudoexfoliation glaucoma is said to be present when characteristic optic disc changes and visual field defects occur due to raised intraocular pressure secondary to pseudoexfoliation. And pseudoexfoliation glaucoma occurs in 1/3 of pseudoexfoliation patients. Pseudoexfoliation glaucoma is said to be the most common cause of secondary open-angle glaucoma, and this is important to remember. It is said to contribute to 20% of all open-angle glaucoma cases globally, and as many as 50% of all open-angle glaucoma cases in Scandinavian countries. Rate of progression from pseudoexfoliation to pseudoexfoliation glaucoma is reported to be as high as 40% in 10 years' time, and pseudoexfoliation glaucoma is much more aggressive than either primary open-angle glaucoma or normal tension glaucoma, which is also important to remember. And this aggressive nature of PEX glaucoma is said to be due to higher intraocular pressure, larger fluctuations of intraocular pressure, and greater susceptibility of the optic nerve head, because the optic nerve head also contains elastic tissue. So overall prognosis of pseudoexfoliation glaucoma is worse than primary open-angle glaucoma. Pseudoexfoliation glaucoma has a poorer response to medical therapy as compared to primary open-angle glaucoma, but responds well to prostaglandin analogs, which increase uveoscleral outflow. And 2% pilocarpine once daily at bedtime has been shown to reduce intraocular pressure further and retard the progression of glaucoma, as pilocarpine is said to reduce the friction between the posterior surface of the iris and the exfoliative material on the anterior surface of the lens, reducing dispersion of pigment from the posterior surface of the iris. Raised IOP in pseudoexfoliation responds well to laser trabeculoplasty, but temporarily. Success rate of trabeculectomy in pseudoexfoliation glaucoma is similar to that in primary open-angle glaucoma, and minimally invasive glaucoma surgery along with extraction of the cataract can be attempted in early glaucoma. But pseudoexfoliation patients are known to have more severe inflammation following ocular surgery. Cataract surgery in pseudoexfoliation or pseudoexfoliation glaucoma is a special situation which needs separate discussion. Cataract surgery in pseudoexfoliation glaucoma can decrease IOP by widening the angle. But the difficulties faced during cataract surgery in pseudoexfoliation or pseudoexfoliation glaucoma include, as we have mentioned, zonular weakness and inadequate pupillary dilatation. Poor dilatation of the pupil is said to be the single most important predictor of vitreous loss in pseudoexfoliation. Following surgery, there can be severe post-operative inflammation along with posterior synechia formation, and post-operative intraocular pressure spikes are known to occur. Late onset capsular phimosis, as shown here in this photograph, and late onset IOL dislocations are well known following cataract surgery in pseudoexfoliation patients. Recommendations for cataract surgery in pseudoexfoliation include pupil expansion, larger capsular axis, which helps in prolapsing the nuclear fragments with minimal zonular stress and also helps in reducing the incidence of capsular phimosis. Capsular support devices such as capsular tension ring with or without a sterile fixated capsular tension segment, which decreases stress on zonules intraoperatively and also helps in IOL centration and in reducing capsular phimosis post-operatively. Both gentle but adequate hydrodissection is required whenever there is zonular weakness, and these techniques we'll be discussing further in the section on cataract. Differential diagnosis of pseudoexfoliation include primary open-angle glaucoma, which we have discussed in a previous session, pigment dispersion syndrome, which we will be discussing next in this session, primary familial amyloidosis, in which fleck-like material resembling pseudoexfoliation material can be found to be deposited on the anterior lens capsule, and a rare entity called true exfoliation of the anterior lens capsule or glass blower's cataract, in which there is splitting or delamination of the anterior lens capsule in scroll-like layers due to exposure to heat, irradiation, trauma and inflammation, and it is called glass blower's cataract because it is found in people employed in this profession because of their exposure to significant heat. But true exfoliation is not associated with any material deposition or glaucoma, as in pseudoexfoliation syndrome. Another well-known cause of secondary open-angle glaucoma is pigment dispersion syndrome, also known as PDS, in which there is rubbing of the posterior surface of the iris with the zonular apparatus of the crystalline lens, leading to dispersion of pigment granules. So whereas in pseudoexfoliation syndrome, in which there is a rubbing of the posterior surface of the iris with exfoliative material on the anterior surface of the lens, in pigment dispersion syndrome, there is rubbing of the posterior surface of the iris with the zonular apparatus of the crystalline lens, and a posterior bowing of the mid-peripheral iris, called a reverse pupillary block, increases the contact of the iris with the zonules. And it is said that in anatomically predisposed eyes, such as in myopic eyes with deeper anterior chambers, Blinking, accommodation and exercise results in the iris squeezing out aqueous from the posterior to the anterior chamber, leading to a pressure gradient between the anterior and the posterior chamber, with the pressure in the anterior chamber being higher than that in the posterior chamber, and this results in posterior bowing of the iris along with a pupillary block called a reverse pupillary block. It is called reverse pupillary block because in conventional pupillary block, which occurs in primary angle closure glaucoma and which we have discussed in the previous session, the pressure in the posterior chamber is higher than that in the anterior chamber and the mid-peripheral iris bows forward. And UVM studies have shown that prevention of blinking decreases this posterior bowing of the iris in pigment dispersion syndrome. Anatomical factors which predispose towards this pathophysiologic mechanism in pigment dispersion syndrome include deep anterior chamber, which we have mentioned, larger iris, posterior insertion of the iris on the ciliary body, as well as a developmental abnormality of the iris pigment epithelium, which is said to promote release of the pigment granules from the iris pigment epithelium. PDS typically occurs in a younger age group and is more common in myopic patients. Pigment dispersion syndrome is found equally in males and females, but glaucoma due to pigment dispersion syndrome is much more common in males than in females, as we will discuss. With increasing age, the thickening of the crystalline lens decreases the contact between the iris and the zonules, leading to gradual decrease and even disappearance of signs of pigment dispersion by 6 to 7 decades of life. So the phenomena of pigment dispersion in these patients occurs in the mid-decades of life between 20 and 50 years of age, during which intraocular pressure increases and glaucoma is likely to occur and progress. But at a later age, pigment dispersion ceases and glaucoma no longer progresses, and PDS has been found to have a polygenic inheritance pattern. Patients with pigment dispersion syndrome can have symptoms as episodes of ocular pain, colored halos around lights and blurred vision, particularly following exercise and mydriasis. These cluster of symptoms resemble those found in patients with primary angle closure having subacute attacks. Following exercise and mydriasis, there can be severe elevation of intraocular pressure due to sudden release of a large amount of pigments from the posterior surface of the iris. And these episodes can be prevented with pilocarpine, which reduces the posterior bowing of the iris. But pilocarpine, on the other hand, increases the risk of progression of myopia and also the risk of retinal detachment in these myopic patients. The most common clinical sign which arouses the suspicion of pigment dispersion syndrome is occurrence of Krukenberg spindle on the corneal endothelium, as seen in this photograph. And Krukenberg spindle has a vertical spindle-shaped distribution of pigments on the corneal endothelium. And this distribution is said to occur due to aqueous convection currents as well as phagocytosis of pigments by the corneal endothelial cells. But Krukenberg spindle is not necessary for the diagnosis of pigment dispersion syndrome and may also be found in other conditions such as pseudoexfoliation. On gonioscopy, pigment dispersion syndrome patients demonstrate homogeneous and dense pigmentation of the entire trabecular meshwork. And we may recall here this is in contrast to pseudoexfoliation patients in whom the pigmentation of the trabecular meshwork is patchy. And Sampao-Lazy's line, which is deposition of pigment anterior to the Schwalbe's line, which is typical of pseudoexfoliation syndrome, can also be found in patients with pigment dispersion syndrome. In pigment dispersion syndrome, the iris demonstrates posterior convexity or posterior bowing, as we have discussed, and there can be spoke-like transillumination defects in mid-peripheral iris, which typically occurs first in the inferior angle. But these spoke-like transillumination defects may be difficult to appreciate in a thick brown iris. And with increasing age, these transillumination defects may fill in and disappear as the rubbing between the posterior surface of the iris and the zonules decrease with age. And with a light-colored iris, pigment deposition on the anterior surface of the iris may cause heterochromia. In the crystalline lens, there can be pigmentation of the equatorial region of the lens capsule, which is called a Z-Myers line or shy stripe, as seen here in this photograph. And pigment deposition may also be found on the zonules and the anterior hyaloid. Pigmentary glaucoma is defined as occurrence of raised intraocular pressure in a patient with pigment dispersion syndrome resulting in glaucomatous optic neuropathy with characteristic optic nerve weight changes and visual field defects. And only 15% of pigment dispersion syndrome patients develop pigmentary glaucoma in 15 years' time. And as we have mentioned, pigmentary glaucoma occurs more commonly in males than in females in a 3:1 ratio. Pigmentary glaucoma is detected at an earlier age in males as compared to females. Raised intraocular pressure is due to obstruction of the trabecular meshwork by pigment granules, and the trabecular endothelial cells which line the trabecular beams phagocytose these pigment granules, following which they degenerate and die, and macrophages carry off the pigment and the cellular debris, leaving denuded trabecular beams which collapse and obstruct the trabecular outflow pathway. And this explains why laser trabeculoplasty is effective early in the disease process but fails to produce an effect later in the disease. Pigmentary glaucoma responds well to IOP lowering medications, laser trabeculoplasty and surgery, and the efficacy of prostaglandin analogues to lower the intraocular pressure in eyes with pigmentary glaucoma has been found to be better than that with beta blockers. Selective laser trabeculoplasty can lower intraocular pressure in eyes with pigmentary glaucoma but has a temporary effect for a few years. And as we have mentioned, trabeculoplasty is effective only early in the disease process, but trabeculoplasty may cause paradoxical rise in intraocular pressure in eyes with heavily pigmented trabecular meshwork, so a lower energy setting and treating only 180 degrees per sitting is recommended when performing laser trabeculoplasty in eyes with pigmentary glaucoma. And filtering surgery such as trabeculectomy in young myopic male patients can cause hypotonic maculopathy. As there is a reverse pupillary block in pigment dispersion syndrome, laser iridotomy has been attempted to negate this reverse pupillary block, but it has not been found to be effective in pigment dispersion syndrome or pigmentary glaucoma. Differential diagnosis of pigment dispersion syndrome and pigmentary glaucoma include other conditions in which there is pigment dispersion in the anterior segment, and these are pseudoexfoliation, which we have discussed earlier in this session, uveitis glaucoma hyphema syndrome, which usually occurs with malpositioned intraocular lenses following cataract surgery, ocular trauma, uveitis, and melanocytic tumors. Pseudoexfoliation syndrome is a systemic disorder of the extracellular matrix and is the most common cause of secondary open-angle glaucoma. Most patients of pseudoexfoliation have mutations in the LOXL1 gene. Pseudoexfoliation material is an extracellular fibrillogranular material produced as well as deposited at various sites in the anterior segment of the eye. Pseudoexfoliation is found more commonly in elderly individuals and usually has an unilateral or an asymmetric presentation. Clinical features of pseudoexfoliation include a characteristic bullseye pattern of deposition of the material on the anterior lens surface, deposition of the material on the pupillary margin, variegated pigmentation of the trabecular meshwork as well as pigmentation anterior to the Schwalbe's line, peripupillary iris transillumination defects with a moth-eaten appearance, inadequate pupillary dilatation and zonular weakness. Pseudoexfoliation glaucoma occurs due to obstruction of both the trabecular and the uveoscleral outflow pathways by these deposits and is characterized by raised intraocular pressure with glaucomatous optic neuropathy. The intraocular pressure levels in pseudoexfoliation are higher with larger diurnal fluctuations as compared to primary open-angle glaucoma. Pseudoexfoliation glaucoma is more aggressive and has a poorer prognosis as compared to primary open-angle glaucoma. Pseudoexfoliation glaucoma can be treated by hypotensive medications, particularly prostaglandin analogues, trabeculoplasty, and filtering surgery. Cataract surgery in pseudoexfoliation is challenging because of inadequate pupillary dilatation, zonular laxity, post-operative inflammation and IOP spikes, and late occurrence of capsular phimosis with IOL decentration. Pigment dispersion syndrome occurs due to release of pigment granules from the posterior surface of the iris when the posterior iris surface rubs with the zonular apparatus of the crystalline lens. A reverse pupillary block causes backward bowing of the mid-peripheral iris. Pigment dispersion syndrome occurs more commonly in younger myopic patients. Pigmentary glaucoma occurs more commonly in males as compared to females, and pigment dispersion decreases and disappears with age. Clinical features of pigment dispersion syndrome include Krukenberg spindle, homogeneous and dense trabecular meshwork pigmentation, and pigment deposition on the equatorial lens capsule. Rise in intraocular pressure occurs due to obstruction of the trabecular meshwork by pigment granules, followed by destruction of the trabecular meshwork, and IOP spikes can occur following exercise and mydriasis in patients with pigment dispersion syndrome. Pigmentary glaucoma occurs in the 4th and 5th decades of life and is more common in males. Pigment dispersion syndrome should be differentiated from other causes of pigment dispersion and raised intraocular pressure such as pseudoexfoliation, uveitis glaucoma hyphema syndrome, ocular trauma, uveitis, and melanocytic tumors. Pigmentary glaucoma can be treated by hypotensive medications, particularly prostaglandin analogs, trabeculoplasty, and filtering surgery. And patients with pseudoexfoliation or pigment dispersion should be treated as glaucoma suspects and followed up carefully. Thank you for listening.